We've always realised that there are huge gaps in how we can provide services to people who have opioid use disorder. And initially, the message that I was hearing was, oh, let's be cautious, let's give it to those who are stable, it'll be great for those that like to travel, what about those people who have got jobs, who can't get to the chemist every day? And yes, definitely, but my thought went to, what about these people that we just can't get past first base? What about these people who are so chaotic and so high risk and so at the margins of society? Those that have complex dual diagnosis, that one where you can't fix one until the other is fixed, and yet the other can't be fixed until the other one's fixed, and you just seem to be trapped. Those who are high risk, polysubstance misuse, recidivism, in and out of prison. This group seem to have lost hope, that actually now we've reached a point where we can't engage them. But then the other side of the coin is that there were service users that just never came through our door. They got as far as the first phone call. They discovered that initially going onto a medication would involve a chemist, would involve going in every day. And actually, perhaps they hadn't got that bad for them. And they looked at the consequences of how that would pan out in their lives. And they just put a line through it and went, I'll just carry on managing my heroin addiction. They'll hear what's involved in treatment and they'll just go, no, it's okay. And then sadly, things deteriorate. But actually, what if we could reach that group earlier and treat them at an earlier stage?
When we first started with our Buvidal experiment, not many people were very keen on it. It was almost the new drug that nobody wanted to have. I think their biggest fear was the fact that we were going to take their control away from them. We were going to be administering a drug, and therefore how were they going to feel at night when they had nothing to take? The actual stable group, I equally had a sort of a negative response from them, saying, it's not broken, why should I fix this? I don't want to change. So I think the most important thing is thinking about your eligibility criteria. If you don't have a good eligibility criteria, you cannot just have everybody and anybody going on Buvidal, because the bulk of the majority of OST will still be the traditional forms of OST. So what you have to look at is, if you're starting a service, is to try and make sure that you've got your eligibility criteria carefully mapped out. We had this very innovative way of doing it. We had the very stable group, so we didn't really have to have really strict criteria. They just had to be stable. And then the sort of chaotic group, well, anything went as long as they turned up. The problem with that is, at the start that worked, but as the program became more and more popular, one of the problems now I have 8 months, 9 months, a year down the line, how do I manage this expensive resource and try and make sure that the people who get it are the ones that you can help the most? A prescribing service needs to be cost effective, but at the moment, when you got a dose of methadone being 65p, and there's an injection that costs £240 a month, people do say, well, hang on a second, we're not prepared to pay that level of investment on something. So when you're setting up a service, you really need to think about how you're going to deliver Buvidal. Have you got an existing dispensing model? What is your current pharmacy model? Are they able to adapt to administering Buvidal? Is your pharmacy able to take on any extra work? So I suppose the most important thing is to look at capacity and decide on numbers. You're going to have the capacity, the clinical capacity, to administer the injections, because this becomes quite a logistical headache, and making sure that they get their weekly doses, and there's somebody to dispense the medication, sign the prescription, and then actually administer it. It helps if you can order the Buvidal directly from the wholesaler and have it on site. If you got 250 clients in a setup, you cannot have 250 prescriptions flying back and forth and the stock being brought back into each base or administration center on a daily basis. So you obviously need a home office license. If you've got 4 sites that you want to administer Buvidal from, you would have to have 4 different licenses, and all those 4 sites would have to go through the same checks with the home office before they issue the license. And it's an annual license, so unfortunately every year you're going to have to renew the license, and go through the same scrutiny that happens with the initial issuing of license. You obviously need the paperwork, the standard operating procedures, the prescriptions, and then the training of the staff. I mean, that's not difficult. Administering Buvidal is not difficult at all. And then the most important thing in the dispensing model is having a tracker, a piece of software or an Excel spreadsheet that you can track the number of clients on your program, their start dates, their weekly injection follow-up dates, the expiry dates, their test results. All that needs to be in a very comprehensive spreadsheet so that you can actually see what you're doing. So the pharmacy model is a lot more easier to set up, and actually most people who will probably want to start slow might want to get stuck into the pharmacy model. It works because you have an existing community pharmacy setup who's probably administering buprenorphine or methadone for you. So all you have to do is to change your prescription from methadone to buprenorphine to Buvidal. This obviously requires cooperation for the pharmacist because they will need to order the Buvidal in advance. There needs to be understanding that once the Buvidal is ordered that you are going to use it, because it's a very expensive drug and there's nothing more annoying for a pharmacist than to order a couple of Buvidal, have it on the shelf, and for it not to be used. At the end of the day, the vast majority of our OSD patients on methadone and buprenorphine are doing well. So target your patients carefully, select them carefully so that, if somebody is going to do well on methadone and they've always done well on methadone, I still think that they should be allowed to start on methadone and continue on methadone. But if they are having difficulty stabilizing, titrating, attending, or sticking to the criteria of what is good engagement, then I think we should then offer them Buvidal. And then finally, my last bit is your exit strategy. People will want to gradually move off Buvidal because they want to exit treatment. Now, with Buvidal, there isn't a lot of discussion to have because you've just got 3 monthly doses. And as Bern said, you can start reducing the injections. So you can come down your dose from, say, if you want 128, you can come down to 96, and then come down to 64, and then maybe after 2 months of being on that lowest dose, you can start to think about how you wean them off Buvidal. There are 2 ways of doing it, either to simply let the injection run out or to convert them to the equivalent oral sublingual buprenorphine and then titrate them off that. And that would be the exit strategy.
Until August, from when I put my first SARS-CoV-2 Buvidal patient on my spreadsheet, I had 177. And on entering treatment, nearly 3/4 of them had a clinical global impression of 5 or more. So they were very sick people, very adversely affected by their illness. And then I did a review of that caseload, and what we saw was a significant percentage, about 80% if you add up the 5, the 41 and the 34, had significantly improved that clinical global impression. So that they dropped it from between 5 and 7 down to either some of them moving by 4 points down, or the vast majority moving between 1 and 3 points down. So seeing quite significant improvement in a very hard to reach group. We've got to keep remembering that this was a cohort that we couldn't reach. This was a cohort of chronically street homeless, spice using, very hard to reach people. And 90% of them were still in treatment when I reviewed this caseload on Buvidal. So in terms of treatment retention, this is something completely different. This really does give us an opportunity to retain people in treatment. For those patients with favourable prognostic indicators, the vast majority, they do incredibly well on Buvidal. And maybe it can be a gateway to a deeper and more meaningful level of recovery than we've ever quite achieved before.